Well, the word is out, it's changed, yeah.
All right, folks, welcome back. After a long summer, hopefully everybody had a good time and it was safe. We have a pretty busy agenda today. Many changes coming to us from Mohawk and their critical care program, some other interesting things. But what I'd like to do with the agenda, if it's all right with everybody, is actually start with a presentation from Diane Abley. Diane comes to us from the Lifestar Trauma Program and is the administrator of the local or the Regional Trauma Advisory Committee. Yes? Okay. And has some trauma registry data that I had asked her to bring to us. Frankly, looking it over quickly, it's interesting, and I think there are a couple of different ways of looking at it, and I think we'll all have something to add and to chat with her about as we look at it. So, Diane.
Okay, I have two agenda items today. First, the data that I brought for you. I ran this on 2012 data, which is complete and all entered. We still haven't kind of caught up to where we should be with the 2013 data, so hopefully when we get more on board, I'll be able to come back and present some more for you. I ran this data on EMS transport. I sorted out by air transport and the subcategory of air transport transferred from another facility to Albany Med, and then ground transport, and then a subcategory of ground transport brought to Albany Med. I don't have any other data for the other institutions, other hospitals in the area as far as their trauma registry data. I can read this to you, or you can read it yourself. I broke it out by injury class, which is blunt or penetrating, and it's pretty consistent that we're still getting a lot of blunt patients compared to penetrating injuries, although based on the trauma calls we've gotten in the last few weeks, there's a lot of penetrating out there too. Falls are the biggie. Well, it depends on where you're coming from. Falls kind of tie second with motor vehicle crashes. I'll go back a little bit. This data is based on New York State inclusion criteria, which is basically the moderate to severe injured patients. It doesn't count like minor injuries like isolated humerus fractures, and those type of things would not be included in this data. Males are still coming in more than females. That goes with most of the national trends, that you guys seem to be a little more aggressive in your behavior. Average age is, I should have done the trend for over the years. The average age is actually going up. We're getting into the 40s and 50s for our average age now, which means the population is actually growing older, as we know, and the trauma patients that we do see are growing older. It's still young, believe me. 48 is still young. Have the number of transfers to AMC. Date of admission, the weekends are still the heavier days. Obviously, people have more trauma on the weekends. The heavier months are usually the summer months. Although I know for the air medical, it seemed that November was a biggie last year. Most of these patients that come in by air seem to be admitted to the trauma service, which I'm suspecting that they're probably the more severe injured patients. As when you get to the category of the average ISS, you may not know what that is. It's an injury severity score. It's determined by the injuries that the patient has, and it's a calculated number. The higher the number, the more injured the patient. The highest an injured patient can have is 75, and usually they're dead if they get a 75. If they survive those injuries, they're quite lucky. Anything over a 15 is considered a major trauma. Included BMI. The trends have been we're a country that's injured, that continues to get heavier and heavier, but our injured patients seem to come in that way as well. And the average BMI, though, is still within a reasonable range. Average length of stay in the ED at Albany Med, the air patients, the ones that come in by air seem to be staying a shorter amount of time than the ones that come in by ground. I'm crediting that too, that hopefully the ones that are coming in by air are a little sicker than the ones by ground, and they're getting to ICU or the OR faster. Which shows up in the average length of stay in the hospital. Those ones that are coming in by air are staying longer in the hospital. Again, I'm thinking that they're the more seriously injured and appropriately would be staying longer. And then the last section is discharge disposition. Anybody have any questions on this data? Conversation, other fields that you would like to see in future reports?
As I look at it, Diane, I think one of the most important things for this group would be to know where these patients are being transferred from and where they originally were injured. Basically to see, are there things that we can do by educating EMS providers to be able to get these patients directly to the trauma center, or whether or not there were delays to get them to the definitive care they needed. If the transfers that are coming in are all a significant different distance, then it's probably correct. If there's a whole lot of trauma patients, say that Dr. Vogel's sending over from Memorial, we probably need to do some work on educating the providers that are bringing those patients there. If they're all coming from Gloversville, what?
Or the patient's friends.
Or the patient's friends, exactly. Well, and that's an important part, right? If they've gotten shoved out of the car in the parking lot, we have nothing to control for that.
Lot, get their license plate, and then we can educate them as to it.
So I think that's to try to tease that out from the database, and you know the database best.
Yeah.
You'd be able to figure out how we can look at that
We usually get
information.
injury location and actually can always tweak out where the institutions that they're being transferred from.
Yeah.
That's good.
So I think this is just, right now it's very interesting. We can see a whole lot of correlation here. We can't necessarily see causality. Of course, if you look at this and there's one person who's going to say, well, my gosh, if you travel by aircraft, it clearly increases your length of stay in the hospital by 4 days. We all know that's not really what happened here. So, or at least I hope not. So let's be very careful about people looking at correlation and causality as they look at this, and looking and seeing that we do have higher injury severity scores in the air transported patients, which is a good sign. That's what we would expect and what we would like to see. So we need to know more from here.
And I need something
More,
from
please.
this group too.
Mhm.
As you may or may not know, the New York State is changing the way they're verifying trauma centers. And what has happened is the American College of Surgeons is now tasked to verify all trauma centers in New York State. And then a lot of non-trauma centers or community hospitals will be asked also to become either a level 2, 3, or 4 trauma center. This is all going to play out within the next 4 or 5 years. I'm not sure how long it's going to take. Albany Med had their consultation visit from the American College of Surgeons back in April. It seems like it was yesterday, but yeah. There was a lot of work involved in putting this together, but the consultation was to kind of point out what our deficiencies were, what our weaknesses were, what our strengths were, where we can go from here to improve our trauma program, to improve trauma care within the region as well. And we didn't have any deficiencies with EMS, but they did note some weaknesses. When they were reviewing our charts, they noted that there were PCRs missing. There were some what seemed to be extended lengths of stay in the field for scene times. And so they're asking us to work with our regional emergency medical organizations as well as the state to kind of figure out how can we problem solve this issue. We do have problems getting some of our PCRs in the hospital. Sometimes they disappear in the hospital once they arrive. With the electronic medical records, we're having better luck with that, but even sometimes those end up disappearing after we put them in the chart. And then the other piece is the initial scene PCR often doesn't make it to us. So if anybody has any ideas how we can work this out, how we can work together to improve this process, to make sure, because what they're interested in is they need to do a timeline from the time the patient was involved in an incident to the time they receive care at our medical center. And actually, we still have work to do within the medical center to do the times from time of admission to the time they're discharged from the hospital.
With the electronic PCRs, if you don't have them, you can probably just contact the agency and they can send you another copy.
Yeah, and we have actually access to EMS charts and a couple of other ones.
So that works
We
out
can
for
get
you.
them that way. There's still the ones who are still doing paper. I need to investigate how to get the scene ones that, like for instance, if somebody's dropping off for scene PCR, Air Medical brings them in, or an ALS unit brings them in, and sometimes first we don't have that information. So,
Should that information be on the PCR of the transporting agency though? So, for example, if an Air Medical agency arrives and takes the patient from somebody else, they should still list the time of injury, who the service was that initially saw them. So that information should be on a PCR that comes with the patient, right?
If it's a scene call, but what if they're picking up at O'Connor Hospital in Delhi and you're
Most often-
accepting from an ER?
Most often when we get these charts, you know, the copied charts from other hospitals, the scene PCR is in it. So it's, and what we do in the emergency department is we just take that and it becomes a part of the record.
it's been a while since I've looked at your run sheets, but is the first set of vitals in there too, because that's the other thing that we need.
Yeah, may not be, the highest heart rate, lowest blood pressure often
Right.
is,
Yeah.
but not always the first set.
Because that's one of the data pieces that we, and the time that they were on scene too. I'm not sure. I know there's usually like a summary of what
Right,
happened,
right.
but the time of incident, if it was there, and so those are pieces. And I don't know if there's a way to get those scene PCRs. I mean, we've had some problems with some hospitals, not up here as much as downstate a little bit more, who we call for the PCR from their institution and, oh, it's a HIPAA violation, we can't send it to you.
It's so funny that they tell you that too.
That's when the tech puts me on the phone.
So I guess there's education that needs to go out there, and that some of that needs to come from the state level, I guess, as well.
I think if you put a summary together and distributed it of what you're looking for, you'd get better compliance.
Okay. That's
It's a good idea.
Is there a way to capture that information online like we do with CARES?
No. There isn't enough accuracy there. Plus, we're talking about, we regularly get transfers from what, 25 counties or 27?
Something like 27, yeah.
From, just a huge
And if you
scope of
sent that to
county.
the regional, the county EMS advisory boards,
Mhm.
that would be your point of distribution into those 25 counties.
Mhm.
Yeah, I think maybe 15 years ago I may have done this, but it's probably time to do that again.
Mhm. And actually, the transfer center should be a part of that as well. Having the transfer center make sure to request a copy of the PCR to be included. Now, the agencies that don't ultimately have their patient care report completed at the time of transfer are going to be a problem.
And that's always been a
And
problem at
that's
our
not something-
institution, too.
Right.
Because what happens if, for instance, your PCR or whatever information you have isn't completed before you leave, and you come back later and drop it off? Well, it follows the patient around but never quite makes it to the chart. And there's piles of PCRs all over the institution that I've seen that they're just not quite connected. So we have work to do with inside the institution as well. But if anybody can come up with information, ideas, or has any thoughts on this, it would be greatly appreciated from this end of the world.
Anything else for Diane? Thank you very much. Appreciate it. You get to go home now. Exactly. So, from one guest speaker to the next, Brendan Rorden is a PA student from Hofstra who wanted to approach this body about surveying our providers in the field. And with that, I think we've got Brendan coming up down here.
Give me a second.
Okay.
Get Dr. McHugh up here.
Can you hear me?
I got you. Hang on.
Okay.
And are you able to hear us, Brendan?
Yes, I can.
Thank you.
Excellent. And I'll get out of the way.
Good afternoon, everybody. First of all, thank you for having me here. I appreciate you giving some time to your meeting to allow me to speak to you. When it came up to our master's research phase, we are looking to do some evidence-based practice. And having worked as an EMT and an EMTCC in Nassau County, I've noticed that there's a little bit of lack of evidence-based practice, specifically in regards to critical care. As someone who is going into the critical care field, I think it's essential that we be able to recognize and treat certain conditions pre-hospitally. And the one that I'm focusing on is sepsis, severe sepsis, and septic shock, based on the surviving sepsis guidelines that were put out by the SCCM and the European Society of Intensive Care Medicine in 2012. What we're looking to do at this point is just assess how well, as pre-hospital providers, we can recognize, classify, and potentially manage sepsis in the field. So what we did was create a 10-question demographic survey and a 10-question assessment exam based solely on the surviving sepsis guidelines that I referenced earlier. And we're looking to recruit New York State EMT basics, critical care technicians, and paramedics who are active and have them participate in the survey to determine the baseline level of knowledge in regards to these three things: recognizing, classifying, and potentially managing sepsis pre-hospital.
Brendan, do you want to review a couple of the questions you wanted to ask everybody?
Sure, I can actually
just
pull
for
up a
background for the
screen
docs.
share if you guys would like.
Sure.
Bear with me 1 second, please. All right, can you see this?
Get a black screen. There you go.
I know we're going through this kind of quickly, and I'd be happy to follow up with the entire council following this. The first question here is basically just our version of informed consent. It allows people to agree to the conditions of the survey, basically that they know that they need to keep the content to themselves, that they can't share it, that they can't take the exams together, and more importantly, that this is voluntary and they can withdraw at any time by exiting the survey, meaning if they close before they finish the last question, no data will be collected. And if they do click no, they're not able to move on with the survey. So there's some logic built into this software that allows us to determine the way that the exam goes. You can see here what happens if they try to progress without agreeing to the terms and conditions. Next up, we're just doing demographics based on age, level of education, current certification. Again, this question here is sort of exclusion criteria, because if the participant is not an active New York State provider, once the exam is finished, we'll use our software in a post hoc analysis to take out their answers. Initially, I created this next question as exclusion criteria because I wanted to focus on the curriculum that was being taught to New York State EMTs, CCs, and paramedics without the confounders of further education like critical care or nursing or medical doctor. However, I did recruit so many participants who hold these degrees, I said instead of doing a exclusion criteria, we can actually do a side-by-side analysis and maybe use the curriculum that's being put in the critical care or the registered nurse curriculum into our own New York State and see if that might help. Again, more demographics, how long have you been practicing, subgroup analysis based on the type of agency, paid versus volunteered, etc. This question was a recent addition because after speaking with Dr. Daly and seeing that some of the councils had actually initiated a suspected severe sepsis or septic shock protocol, this may help in determine, which councils are being more aggressive and whether or not it's having an impact on their providers' level of knowledge. And also CME, see if maybe instead of adjusting the core curriculum that we can just up our use of CME in terms of educating about sepsis. And then the last question is just on a personal scale, how familiar they are with providing sepsis. My apologies, I need to go back and answer all these questions. I'll just answer them as myself.
Brendan, when you get to the next page, why don't you just review a couple of key questions so we can get to the core of what we're talking about.
Yep, sure.
Thank you.
And again, these questions are actually randomized. There's some, like I said, some logic built into the exam so that no particular provider will receive the same exam and in the same order. So this one is just about the type of shock classified. This is the definition of sepsis, and again, these are defined directly from the surviving sepsis guidelines. This is about a management. Again, this is a ALS based the question, this exam, but most of the exam is based on both BLS and ALS. This is a little physiology question about the systemic inflammatory response syndrome versus sepsis. That's a sort of a gimme question there. This is another ALS question. And then there's a couple of scenario-based questions, and we're looking to remove one of the straightforward questions and replace it with with another scenario question. That's about the physiology of septic shock. And that's another scenario question. And this one, Dr. Daly, I know we had spoken about negative questions. This question is going to be reworded and possibly removed altogether based on the fact that it is a negative question. And again, provided that it remains confidential, I'd be happy to share the content of these questions with the entire council so they can take a closer look at them.
Brendan, I think that was a pretty good overview, and I think it went quickly enough that that folks won't be able to copy them off the webcast. All right.
Right.
Goal being to maintain the confidentiality, just to make sure that you have as good an instrument as possible. All right. So at the end of the day, Brendan had asked if we endorse this and whether or not we were willing to share this with our providers. I think this is something that would be very interesting for us, because we do have a sepsis protocol, and it would be nice to see what our providers currently understand of sepsis, as well as how they compare to other providers in other parts of the state. So I think, Brendan, bringing these results back to us would be something very potentially interesting. But other thoughts from the floor? Wow.
Just as an aside, Dr. Daly, to this point, we've now recruited 140 New York State EMTs, CCs, and paramedics who've agreed to participate in that study. We are looking to get even more, and your endorsement would certainly help us in that regard.
That's great. That's great. Adam?
Is this purely a descriptive study that you're trying to do, or do you have a hypothesis set for this?
It's hard to say because I think we run the gamut in terms of our education of EMTs and paramedics. You'll have some that will go every which way in order to educate themselves, and you'll have some who are just okay with the bare minimum for content. So I'm going to be pleasantly surprised either way, because if it does show that we do have an overwhelming good understanding of sepsis, we can start looking at expanding our assessment tools or expanding our scope of practice, especially as the community-based paramedicine program starts taking effect in this region. On the other hand, if we show a deficit of knowledge among pre-hospital providers, that tells the state that we need to start working on our education a little better, and it also tells our agencies that we need to up our use of continuing medical education to educate specifically on sepsis, given the fact that it is such a tremendous impact on hospital admissions and on ICU admissions. Thank you for your question.
Any other questions from anybody? One of the things that's really important to me is that we don't overwhelm our providers with surveys. I don't know how many other people at the table get a lot of surveys, but they seem to come just all the time, which means that very quickly the signal-to-noise ratio means that you start just not answering any of them. And I don't want our providers to be faced with that. We just surveyed them on intranasal medication understanding, which was actually pretty interesting, and we're going to share those results back with everybody as well, because I'd like to make sure that we give the answers back. And that's got to be one thing that would come from this, would be a result of this survey would have to come back to our providers. They can see what ultimately the answer was at the end. All right, what knowledge has been gained. So if there's no overwhelming dissent, I would say, can we have a motion for endorsing Brendan's study and then sending this survey link out when he has it ready to our providers to facilitate the study of sepsis in the pre-hospital environment?
I'll make the motion.
Thank you, Don. Second? Todd? All in favor?
Aye.
Great. Thank you. Brendan, we'll help you out.
Thank you very much. I appreciate it. Again, if there's any questions that come up after I've left, feel free to, you have all my contact information. I'd be happy to answer any questions to the best of my ability.
That sounds great. Chris will be your point of contact when the survey is ready to go. Okay?
Fantastic.
Great.
Thank you very much.
Thank you. What was that? Dr. McHugh, we're looking up your nose, sir.
He's driving down the road.
The vagaries of webcasting. That's great.
There's something over the lens now.
All right. Let's get back to the business at hand.
Do you have a quorum? I didn't check. We didn't check that at the beginning.
Oh, you're not going to make us do that, are you?
What's that?
1, 2, 3, 4, 5, 6. Me. It's quorum 7, right? 7 your quorum. Good. Excellent. We have a quorum. We have Dr. McHugh as our ace in the hole. Thank you. We have a quorum. Did everybody have an opportunity to review the June minutes? And do I have a motion for approval? Seconded by Dr. Font. Thank you very much. All in favor? Excellent. Thank you. Some correspondence. We have 3 people excused today, Dr. Halpert, Dr. Sakaris, and Dr. Ushkow, who blames orthopedics. Other correspondence. Hoag's Corners will not be pursuing an ALS upgrade at this time. They had come to us and talked to us about that in the past. There has been a resignation from the Remac, and Dr. DiMartino apologizes and said goodbye. She has now relocated to New Hampshire. There is a new Malta ALS coordinator, Peter Lennon. Huzik Rescue Squad had some clerical errors and is now back on the straight and narrow. Joe, that's all set? Excellent. And there's a fire department by the name of Pleasantdale that's going to become a BLSFR. So welcome, Pleasantdale. Thank you. Start with committee reports. Dr. Goino.
Academic, couple things. TXA has been approved for you, obviously, but we're talking about trying to get on the ground. Providers in the state is going to look at that, and hopefully that will happen so we can do it. It's cheap and works, and doesn't really seem to have any significant side effects, so it'd be nice to have it for our trauma patients.
We have found out, though, that TXA does generate an awful lot of email.
In fact, it does, and not everybody in the state agrees with your
I know.
statement.
I realize that.
There will be significant discussion, I believe, at the staff on September 12th.
And hopefully it will pass, but we'll see.
I think it already passed,
Okay.
so the discussion is simply discussion, so we'll see.
It'll be entertaining. If anybody's free next Thursday, feel free to drop on by the Hilton Garden in Troy. Right?
Yeah.
Yes, okay, good.
The next study, I will let Dr. Daly talk about.
No. Tim.
Tim wants to talk about it.
Arthropometry, is that how we pronounce it, guys?
We pronounce it differently every time we mention it.
We've been approached by a group wishing to conduct arthropometry study on our regional EMS providers. From what my understanding is, this is going to be a national study. This region has been selected to participate as one of the national regions involved in the study. What they basically want to do is come size up our people, is the way I understand it. I have a meeting with them next Tuesday here. They're going to come and decide whether or not we have an acceptable facility for them to conduct the study. They need some ample parking space, and they need some classroom and office space. I think we offer all of that. So I'll know much more after next Tuesday morning whether or not this region ultimately will be selected to participate in the study. And I'll keep everybody advised.
Thank you. Rich, anything to add? You've been involved in this one? Okay. Okay, good. Huh?
I would suggest we put Jay through it about 5 or 6 times to take care of the rest of us. Not quite as fit. We talked a bit about dopamine replacement and the 2014 protocols, and we're going to start working on those as well. Scott Bowman sort of chaired a subcommittee for you changing me and Keith. And what we're going to try to do is get the protocols all sent out to everybody again with suggested changes, and once we make those changes, we'll get back to the school committee members. If anybody has any suggestions as to what they want to see in the next protocol that are not there, please contact me, contact Mike, make sure it gets in there, and get things rolling once again.
We actually have a survey tool. It's linked off the website, so anybody who has a protocol suggestion can put it in there. It'll all be in one place. We can get them all into a format so we can review them all together.
And the last is there are a ton of training courses that are about to start. If anybody needs a list, we have them. Probably there's one for, if anybody needs a provider to update or get started, there's tons of them. So it'll fit in there someplace.
Okay, great. Thank you. A few other things, REMSCO just suffered a summer break, and we'll be meeting again in September. CMAC, SIMSCO, and HOC reports will be coming shortly. Important for us all to remember, and I'll tell you now and probably forget to remind everybody again later, but there will be no October meeting because both the CMAC and the SIMSCO will be meeting when we are meeting. Before I do anything else, I'd like to introduce a couple of people. Beth McGowan has joined us. She's from CMT out in Cooperstown and joins us as a representative, just visiting us from Aarons, which is great. She's Director of Operations for CMT. And 3 folks to my right, Dr. Pinto, Dr. Dosick, and Dr. Frisch. Dr. Frisch is a new member of the Remac. Dr. Dosick and Pinto are both residents on their EMS rotations. upgrades as we move forward. Charlton Fire Department is adding some skills. And Averill Park Saratoga Rowing Association and Camp Scatico are doing epinephrine. Public access defibrillation, we have lots of public access defibrillation starting up, which is great. Hopefully we'll continue to see that grow. These are reviewed by the QI coordinator. We are very close actually to entering all of these into a database that will then be part of a national AED database, and we'll have other options from there. We'll continue discussion about that. And now on to the most important part of the meeting, which is the Deb Funk part of the meeting. So I'm just gonna...
I think the most important part of the meeting sits on that table over there.
That's true. So if in order to get through the Deb Funk part of the meeting, anybody needs another cupcake, please feel free to go and get another cupcake.
We can make this very fast.
All right.
Just say
yes.
Dr. Funk has, by email, shared with us some patient care guidelines for critical care transport for her credentialed providers with Mohawk Ambulance. Including with those is also a set of critical care transfer orders. I have hard copies of all these here, but you received all of this by email, so we thought we'd try to kill as few trees as possible in accomplishing these goals. We know that there will be trees falling left and right as this gets further implemented, but Dr. Funk.
Thank you. I did get comments back from several folks. Some of them were typos, and thank you for that. And some of them were concept questions that I was able to answer. Essentially what I'm asking for is this select group of providers has much higher and much closer oversight than the remainder of my team. We do monthly meetings and I review every one of their calls. We're finding as we go out and do these, the critical care transports, that sometimes we have a different idea of what would be best for the patient in several areas than the sending staff necessarily understands, because transport is our business. So for example, an ICU doctor who wants us to take their vented patient out and move them 2 hours down the road doesn't write orders for any pain medicine or sedation because they've been sitting in their comfy ICU bed for the last however long and they haven't needed anything. I'm going to smash them into this teeny tiny little stretcher, bounce them down the road and put them on a different ventilator. I'd like to give them some pain management or sedation, and very often that's just not filled out. And it's not just in those ICU patients. It's sometimes emergency departments are sending patients and they just want to be very cautious, and so they're giving us orders like a milligram of morphine every 4 hours as needed for your 100-kilo patient with bilateral femur fractures. I'd like to be a little bit more nice to the patient than that. So we looked at it for a while and we asked the providers to identify to us, what do you think would be useful? And they said, just let us do what we think is right. And so we identified what they thought was right, and it seemed pretty reasonable, and that's what these protocols are. So for these credentialed providers, again, not all of our providers, but the ones who have 100% oversight, we'd like to have a standing order pain management and a standing order sedation guideline that they can follow if they're not given different orders by the physician. And that's why I included the order sheet. This is the same order sheet that we currently use. The only thing that we did was we took off the what kind of pain medicine and what kind of sedation do you want us to give checkboxes. We tried to make this as easy as possible. It may not be easy for those people who are filling it out regularly, but we have checkboxes for everything that we want them to do, the sending providers to fill out. And then we added at the bottom that we can follow our own standing orders and our own guidelines unless you think otherwise. So I think that and our team thinks that these pain management guidelines and sedation guidelines are reasonable. I don't think they're unsafe, and they're going to be watched very carefully with it. We'd like to be able to do that on standing orders for our patients that the critical care team is caring for. So because it's standing orders, and it's not just the one dose of standing orders that we see that we currently use pre-hospitally, it's for the duration of the transport, I felt it appropriate to come here to ask for permission to do that.
So,
Questions?
Deb, I have one question. So you talk about the scenario where you have inadequate order from the provider that's transferring the patient? You know, the 1 milligram every 4 hours or whatever it
You've
is.
never seen that.
So, will your medics in this situation be able to go to the guidelines if there was a specific order given that they feel was inadequate?
What they would need to do in that case is
Call medical control.
Call me.
Yeah.
So they would need to call medical control, and in that situation, I would want them to call me, because their medical control is the same doc who wrote the order. And it's happened that the provider has attempted a discussion. This patient's trying to pull their AT tube out. You want me to go however long down the road, could I please give them additional drug? And they say, no, I don't want to mask their neurologic exam. You're not going to have a neurologic exam when you pull their tube out and become hypoxic. So the team, attempts to have a discussion. When that doesn't work, they go out into the vehicle and they give me a call and say, I tried, and it didn't work, and can I please do X, Y, Z?
So they understand they have to do that. in order to-
Absolutely, and it either says that at the bottom of the order sheet or in our, I think it says it actually in the guidelines themselves, that if you're given orders that are different from this, in order to vary from those orders, you must call medical director. So I will be getting those calls. I'm thinking that because we didn't put the box here, nobody's going to write the orders. But maybe somebody will write it in. There's a spot for additional orders, but we very rarely see anything written in that spot. But no, we're not going to go rogue. We're just going to try and take good care of patients.
Deb, how do these orders compare to the LifeNet transport
Oh gosh,
orders?
they're very similar.
That's what I was going to say. They shouldn't exactly mirror each other.
Exactly.
Yeah, they
Yeah,
should.
as a matter of fact,
Many times
the
it's the same
format
providers.
looks very similar to those who have seen those.
It's the same providers back and forth, and I think they should
My
mirror.
goal is,
Yeah.
it can't be the same because we don't
Right.
have a nurse on this ground team.
Right.
But my goal is for these paramedics to operate at the same level that the LifeNet paramedics are operating. We can't do the things that require a nurse. But my goal is for them to have the same autonomy and have the same experiences.
And same dose ranges and things like that.
Yeah. Questions or more comments or approval?
Interesting question.
Are you?
All right, how you doing?
Right there.
That was fine. Can you provide a suggested order sheet to at least your most common players so that they'll just kind of write the orders you want? That's kind of what that is.
That's exactly what that
And
is.
that's different from, say, standing orders, which would be pre-existing, all set.
For every one of our critical care transports, we ask that this order form be filled out. And if the sending providers don't have it, our dispatch center faxes it to them. And that request comes, we get the request and we say, please fill out this order form. If you don't have it, here it is. Because this has our ventilator settings and it has the all-important statement at the bottom that says, if something happens, you can fall back on your original protocols.
Right. And on that sheet, the way I read it, I wasn't sure if that was something at the facility or it just existed.
We created this and we give it to the facilities that we work with.
And it makes it very easy for them to do the right thing.
Yes.
It's very hard to
We
do
try.
the wrong thing.
We've adjusted it a little bit here and there, and we've tried to make sure that there are check boxes for every bit of information that we need to have for care and for billing.
Except for dosing, to the extent possible.
We tried with the dosing on the pain management we wrote. What we didn't write, do you want to provide pain management? We wrote, check one box. Morphine at this dose or fentanyl at this dose, and people would cross it off. Come on. So we're just trying to take good care of patients, and it is really hard to have a patient on a ventilator driving down the road who's you're having to sit on. It's not safe. It's not nice, and you can fix that.
Excuse my naivety, but there is no issue with essentially EMS physicians writing orders for EMS providers in this region?
Right. It's because it's an interfacility transfer. We'll take orders from the caring physician or that physician's designee.
The most interesting thing about this, Adam, is actually Deb is bringing these to us for commentary and input, although we actually have nothing to add in terms of whether or not they're approved, because transfers between Article 28 facilities technically fall outside the scope of our involvement. So this is basically a collegial input. My suggestion would unfortunately be a little bit different, which is I'm not quite sure what to do with pediatric fentanyl orders, standing orders on an interfacility transfer, which falls outside the scope of what we do. Technically
have a
outside
lot
the
of
scope of the
ventilated.
CMAC, which is interesting, and therefore falls back to purely and only to DOH policy, which says that it really can't exist. So I think my suggestion would be for there to be a pain management must-have one on here, with the sedation must-have one on here, just to clear all of that stuff up. The other way of getting around that, I suppose, would be by making it with the close retrospective review and saying that therefore we're covered because you're part of every one of these as the online medical control, and maybe even stating that on here as, maybe at the bottom, to beyond that, the Mohawk physician will ultimately be responsible for all patient care on here, but clearly stating it here, saying that we're in charge, I'm in charge, I'm making these orders because it's the right thing for the patients, so that there isn't any question from the regulator. Because I have a feeling otherwise that pain management one may cause somebody to get upset. Matt?
Mike, that raises a question of patients moving from an ER to another facility.
Mhm.
The treating physician has an EMTALA obligation throughout, and if you are stating that there's a different physician in charge of that patient en route, I don't know if you can, I don't know if that creates a conflict. I don't know if there's any confusion as to which physician is responsible for that patient.
I think under EMTALA, certainly the sending physician has the responsibility for the patient until they arrive at the receiving facility. However, I'm responsible for the care that my providers give outside of EMTALA, right? So anything that they're going to do, whether they had an order for it or they didn't have an order for it, I think is going to fall back on Mohawk and on me.
Yeah, I don't disagree with you. I think the question then is what's the obligation to the treating physician if he's filling out an order form, and then there's going to be override of those orders en route.
It's not an override, because I guess if there is an override, if they say 1 milligram of morphine every 10 hours or whatever, and I say, no, give 10 milligrams now, and in 10 minutes give another 10 milligrams if that's what you need, then that is an override, and their documentation would say medical control through that funk, and it would be there, so the documentation would pin it on me. So I don't know that, I'm not following why I need to put something different on the order sheet, other than, we have agency patient care guidelines, regional, state, and other protocols that we're going to follow.
That raises an interesting question, though, because even though you obviously are willing to take responsibility, and it's documented as such, if there's a bad outcome, the transferring physician's being dragged into it, so.
But when it says that in the patient care documentation, Dr. Funk gave orders for such and such, or we gave such and such based on our guideline, and that's a Mohawk guideline, it seems like that physician would be able to kind of get out of the issue. I'm not thinking that what these protocols allow is going to cause an issue. I'm talking about some.
I don't either. I think it's more theoretical than anything. Okay, but
right.
I just, from a medical.
Because this can occur at any point now. If there's an interfacility transfer happening right now, and somebody runs into trouble, and they call any medical control physician and say, "This guy's going to rip a CT tube out. I need to give him X, Y, Z," and the order is there, it's the same thing, right?
It's true.
So I don't know. It's just allowing the providers to do it right from the very beginning, instead of having to haul the patient out to the ambulance, get somebody on the line, and hope that they get somebody that will give them reasonable orders. It allows them to take over the patient, give them the drugs, transfer them over to the stretcher, move them on out, and make them comfortable right from the beginning.
Yeah, here's a question for you. Going back to the concept of standing order. What you're really looking at on that form is an order sheet where the sending physician would fill in the orders that they're sending. The fact that they're filling it out on your sheet isn't really the point. The point is to filling out the right kinds of orders for your folks. A standing order being an order that already exists that they are allowed to do based on whatever.
So we have a combination, and
Right.
this order sheet, specifies that there's a combination.
Right.
Because they're not, if we're transporting a cardiac patient, they're not gonna write, if VFib occurs,
Sure.
it says, follow your protocols at the bottom, so
So
if
would
the
it-
patient has pain, follow your protocols.
So in that setting, would it make it easier to avoid an override situation by just including the pain management and sedation stuff within standing orders and asking the sending facility to not even write them?
Right, and we took it off. This order sheet used to say pain management, sedation, and we'd have, Versed and a checkbox, and fentanyl and a checkbox, and morphine and a checkbox. We took that off.
Yeah.
So that and I don't know, what do you guys think? Is anybody gonna write in orders for stuff? If we say, we got it, it's covered.
As long as they know it's covered.
Yeah.
I don't
And
like
the
it.
provider, ideally, our providers are having discussions with the center staff. And we can say, don't worry about pain management, we got it covered. Don't worry about, we're thinking of getting some Versed, what do you think?
Right, to
Or,
that
I
extent,
don't know that I
it
would say
sounds
that,
like
actually.
you sort of limited the possibility of having to override
Right.
orders as much as possible.
Yeah,
Makes
that's why we
sense.
took it off of there, so that we didn't run into the 1 milligram every 2 hours, which is oddly common.
I guess my only comment then would be, do that as much as you possibly can and have the most limited
Yep,
possible
yep.
options for orders, including
It-
oxygen and everything else.
It's pretty limited. It just gives us the, who are you gonna call, where are we gonna go, what are the ventilator settings that the patient is on, and, what drips do you have running that you want us to continue? It gives them the opportunity to write additional orders, but we don't really want that. What do you think?
So what happens on the flip side?
Yeah.
If the person writing the orders writes something ridiculous, like, you need to punch him in the face every 5 minutes.
Yeah.
Obviously, it's ridiculous, but what is your crew's responsibility in those cases? I come from a place where our critical care transports, before they left the bedside at the hospital, would call us, give us a full report, and essentially the physician on call for EMS would take responsibility for that patient from the moment they left the bedside. It was the only referring physicians to choose the right transport mechanism, but after that, it was on us to make the decisions after that. So I guess, is there a clause in there if the orders seem ridiculous,
Yep.
to go the other way?
And we do that currently. If we get, there's lots of things that our providers get asked to do or that are ongoing that our providers believe that there's a better way to do. And so what we do is we approach the sending physician and say, so doc, in my experience, the last time I took care of a patient who was going to Albany Med, the neurosurgeons liked not to actually have the patients punched. They actually preferred for them to have this. Maybe, would you mind changing the orders to reflect that? So all done in a customer-friendly way, not suggesting that somebody has written something wrong, because maybe in your residency you learned to punch somebody in the face. But what our guys do, and we don't want to suggest that it's the paramedics' idea, because God forbid paramedics should have an idea. But it's our protocols, our guidelines, our neurosurgeons. It's good to blame things on the neurosurgeons. So there's a discussion, and if they don't get anywhere with it, and they're still very uncomfortable with it, they call me. And if it's significant, like this patient needs to be intubated before they leave this department, and the doc says, no, I don't think so, and they don't think it's safe to bring a patient out, they'll call me before they leave, so that I can then have a discussion. And oddly, that works. Doc, I think something has changed since the last time you saw the patient. They're now blue and apneic. I was hoping that you could come in and help me stabilize them before we leave. Not that this happens at any of your facilities, but you can imagine. So we have that discussion. They address their questions, and most times it gets resolved. If it doesn't, they call me. And I don't either get that many phone calls. Any other questions or comments on the pain and sedation? Hopefully the next one is easy. As we've been moving these patients, we've discovered that there are additional things that we're being asked to do. Last time we came and said, we're seeing new drugs, but same classes. So can we just be approved for classes, and every time we see a new specific drug, we'll train it? Well, we did that, and it's working out well. One thing that we were recently asked to do, and of course it never comes in ones, it comes in threes, we were asked to move a patient with a transvenous pacemaker. And the paramedic called me and said, so there's this wire sticking out of this line in this patient's chest. And they tell me that this pacemaker thing is just on standby and that I don't have to worry about it. Can I move that patient? I said, yes, with a nurse who knows how to use that wire thing with the pacemaker thing. But then we got to thinking about it and said, you know what? We pace. We're trained to pace. In basic paramedic school, it's just a different machine. And I'm pretty sure we can teach people how to use a machine. So we took the, again, this is going to look familiar to anybody who's seen LifeNet's guidelines. We took the LifeNet transvenous pacing guideline, rewrote it to be more specific to our needs, brought Mike McAvoy in to train our providers, and everybody's very comfortable and now credentialed with, of course, your approval that this falls into the same category of care and within the scope of practice. Of course, after we saw that one, we saw a couple more. We're like, oh, we need to get this approved, and we need to get this trained so that we can move these patients without having to take staff along. So we wrote it all, and there's a lot of pages, most of which is for review, and the providers will have this so that, you know, if they haven't seen a transvenous pacemaker in a while, they can open it up and see their pictures and review what it is that they're supposed to do and what they're supposed to document, and it's all right there. Again, I don't think that it's outside the scope of practice. Paramedics know how to transcutaneously pace. It's just a different machine.
Are you giving them their own transvenous pacer to bring with them?
They're taking the hospitals.
Taking the hospital?
And they're taking a battery from the hospital.
So they don't have to worry about switching it over onto a new device? It's working, you
Yep.
go, good, goodbye.
Yeah, I think it does say that in there.
Yep.
You'll bring an extra battery and you'll bring the device. One sentence that may be nice to add in there, which I don't think it was in there, was paramedics are not credentialed to start transvenous pacers.
Like float the
Like,
wire?
Yes.
Okay, I can add that. We don't have the equipment.
I know,
but I can
but-
add that to be certain, yes.
When I first looked at the title, I'm thinking,
Yeah.
oh, we're going to have them starting these now?
Nuh-uh, because then I would never. get
Whatever
to do it.
everybody thinks, if you think that's just a useless statement, or if you think it's
Will
of
not
any value.
initiate.
Yeah.
Well,
Maintenance.
Place.
Maintenance transfer.
How about place?
Place.
Yeah, because,
Will not place.
because initiate,
Right.
that sounds like you
If they
can't
need
turn
it,
the
they
thing
need it.
on.
Okay, I can add that.
If you could snake a drain.
You mean, we didn't approve Central Lines for paramedics to start?
You could also just change the title to maintaining transvenous
Maintenance
pacing, and that
of,
would be,
yes.
Yeah,
that would be even
maintenance of.
better,
Got
and
it.
remove anything. You know, I will never forget the time I was in a little hospital in West Virginia where they said, you can take the patient, you have to take the patient, but we need to keep our pacemaking box, and you have to transfer them over to yours. And mine wouldn't capture, and theirs was working beautifully. And the charge nurse actually wouldn't let me take their box. So I told them they were keeping their patient. Of course, at the time, they said, well, we're going to call the doctor. And I said, I am the doctor. We're not taking the patient. The fun of staff.
Hmm.
We
That's a
ended
good
up
idea.
FedExing it back to them the next day.
It works.
There's no second. Yeah, exactly. We FedEx the patient. Yeah, that part of West Virginia, by the way, does have next day FedEx.
So what do we have to do, given that these are guidelines and not outside of the scope of practice necessarily? Do we need approval for these documents? And if they're interfacility patients, et cetera?
It would be perfectly appropriate for us to endorse them.
Okay.
It's a group. Provider for endorsement. And then we'll have a second. Dr.
Second.
Doyna, Dr. Bosco, all in favor?
Aye.
Dr. McHugh's hand up back there?
Oh, there
Dr.
he is.
McHugh's hand is up. Thumbs up. Excellent. Thank you, Dr. McHugh. I love technology. This is great.
He looks like he's in the passenger seats now.
I believe he is in the passenger seat now.
He was.
Oh, there we go. He's in the passenger seat, good shot.
And I have one last request that has no detail. Again, for our critical care transport team, we have been faced with occasions where the patient needed to have neuromuscular blockade during the transfer, and that makes me uncomfortable not having providers trained to utilize those drugs. They certainly can maintain them, but gosh, now it's a paralyzed patient, and what's going to happen if that tube comes out? I'd like to train them in the region's standard medication facilitated intubation. We'd like to add neuromuscular blockade succinylcholine. We haven't decided between rocuronium and vecuronium, and our standard sedatives. So we'd like to begin that training. We expect it to take probably the next 3 months. And when I have more details on it, I could bring it here. Again, it's going to be kind of a long process to get it done. But we'd like approval to train to them, just again for these providers.
And Deb, you're going to follow the two medic guideline on all these people that are...
So one of my questions is yes. My motto for LifeNet is we train together and we play together, and I don't think this is a one-person skill ever. So we have to figure out how to, how we can train enough providers so that we know that there's always 2 people there. I don't want to have this as a skill and then not be able to use it because we don't have 2 people there. So that's something that we have to figure out. What are the current guidelines for, are there current guidelines for number of hours, for what has to be covered, for the providers, what's a trained and what's a credentialed, or is that completely up to the medical director of the program?
There's some basic regional standards and some regional training materials,
which
will
have and would like to update.
Please do. Please do. This is basically a sourdough process. What you add to it will ultimately grow all of the providers. So please do.
But in terms of people being present, is there a standard for the requirement of the training of the second provider?
They need to be credentialed. One has to be...
One has to be credentialed, one has to be trained.
And the definition of that is, what's the difference between credentialed and trained?
The trained would be an awareness to what's going on, what the drugs that are being used are.
So they haven't necessarily taken the same class.
Right.
But they are competent to be able to assist.
No, they've taken the same
Then why
class,
aren't they
but
credentialed?
it's the medical director who decides who is credentialed and who they feel is just to the trained level.
So
when you decide that they're confident enough to do it, you can basically say they're credentialed. I mean, does that make sense to you?
Do they have to have done a certain number to become credentialed?
We ever set a certain number?
No, we didn't set it. We didn't set a specific number. We didn't set a specific number of hours, which is things that get
when
in
you
trouble
feel
from time to
comfortable
time.
that they're...
Right. I know who I'm going to credential, but it's the training side that worries me. Yes.
I think it was originally left as the education is exactly the same. Matter of fact, I want to say Glenn wrote it. And then it was up to the medical director specifically to decide who actually gets credentialed or not, but everybody goes through the same education.
And the credentialed person is the person in charge.
Correct.
We'll work with that.
I mean, hopefully eventually everybody will be credentialed. There won't be an issue. You have to have where you plan to move everybody to your group.
I think everybody in our critical care group will be credentialed,
Right.
And that's imperative for me. Or frankly, if they're not able to be credentialed in this, they shouldn't be on the team. So that may help us a little bit. But there may be circumstances where it's not 2 of our team members that are on the truck. So we'll have other providers there. So we have to figure out how to get that done. But that's on us. So yes, give you materials. Got it. Done. I think that's all I have.
Really?
Was there something else I had?
Actually, I don't think so. That may be everything. Wow. All right. One last element of new business, which is that the iPhone protocol app has entered beta testing right now. So for those of you who are beta testers, if you get an email from Jeff Midgley at Jam Innovation, please answer the link from your phone, and you will be enrolled in the beta testing process. We're just looking for errors on there. It will be providing phone contacts through to the hospitals of your choice, divided up ultimately by region. So for Arams, Mountain Lakes, and for Remo, you'll be able to click what your selected region is and then have those hospitals available to you. The other thing that it's got is it'll also have directions on there. So when you click on the hospital for directions, you will get directions from where you are to that hospital. There are a couple of bugs in there. That's why they call it beta testing. First time I clicked on Albany Med on the beta test, it took me to the middle of the Adirondacks.
Cool.
Scenic, but not right. So,
Or mileage charge.
a lot of mileage charge, that's true. But although I don't think they allow the physical mileage for something like that. Have to check.
Mike, just so you know, there is a protocol out for, which I guess is our
That's
program.
exactly the protocol app we started with. SREM's app was built by JAMB Innovations.
Okay.
What we've done is update that to our protocols, our hospitals, our directions, and cover picture that's our cover art. So-
The one thing I love
Yep.
about it is I hit the medical control button, I'm on my phone, and I hit Wilson Region Medical Center, and it dials Wilson Regional Medical Center for me.
Yep.
Our
And
app
there's-
includes recording system.
Yeah, it'll take you through the Remo recording system right now rather than going outside of that, so.
Just so you know.
Yeah, no, it's a great app. And what we've tried to do is make sure people knew that our local one was coming, but a lot of people are using that already.
It's just an Apple product right now.
Just available for Apple right now.
ER Finder is available for Droid as well. ER Finder app, free, download it, works Apple and Android.
Does it get you there faster, like a click your heels 3 times?
No, but it gives you the closest proximity to your hospitals. You get the pin, you just pick the pin, and it gives you the fastest route to get there.
If you click your heels together 3 times, you end up in a hospital in Kansas.
Well, if you're out in the middle of nowhere, which is the closest, A or B? You know?
As close as drive time. as opposed
Well,
to-
it gives you the pins, and it'll give you the closest, like 3 closest, or only closest, or whatever you have available to you. It drops little pins
Your
and tells you
world.
where they are and how far away they are. ER
How far
Finder.
away, just as the crow flies, or drive
But
time?
drive
Google
time.
Maps.
ER Finder.
All right. 2 other little notes I have to myself. First, there have been a couple of episodes of humorous IOs being misplaced and placed into either the scapula or the clavicle.
They're close.
Oops. There have been no untoward outcomes for the patients. What I would ask is a couple of things. First, we are building some additional training materials that will be available on the website for all of our providers. The second is, if anybody hears of a misplaced humorous IO, please drop me a note so I can then circle back to the agency medical director, and we can make sure that the appropriate training is done. If you look at the literature on IOs, the tibia is really easy to hit. It's still not 100%, but it's really easy to hit if people do it well. The humerus IO is probably the best IO location. The flow rates are fantastic. The drugs go straight into the heart. On the other hand, if you look at some of the literature out there, it's showing around a 70% or less success rate. All right? So if we have any gross errors, all right, please make sure that I hear about them so we can follow up on that, so we can make sure to get people trained right. This is a great location. I don't want to lose that location. I want to make sure that we're doing good training to address a problem. All right?
If everybody at this table, I mean, it's obvious to us that we want to know when our providers are misplacing IOs, because unfortunately both of these were mine, different agencies, but I wouldn't have known unless somebody called me, and I wouldn't have known that these individual providers needed retraining unless somebody called me. So we should communicate to all of our colleagues. Nobody's going to get in trouble, because the first one, the doc called me and said, "I'm really sorry. He was a really nice guy and everything, but I just need to let you know, but he was really nice. He didn't mean to hurt anybody." Yeah, I know, but, so nobody's going to get in trouble. We just need to know so that we can provide retraining. And this goes with everything that our providers do. So I would encourage everybody at this table to talk with all of our colleagues and say, bring it to us and let us know so that we can provide the training.
I agree with your comments, Deb. Just a housekeeping issue, Mike. I think it would be very helpful for people to have a master list of the agencies with their medical directors and their EMS coordinators, because it's not easy always to find.
Just take his number.
I know.
You find
Well,
them
that's what
all.
I do. I call Mike to find out
That's
who I
what he
need
tells
to talk to.
everybody to call.
But it would be, I think it's something we should have available.
That would actually be something really, really good for us to build into the website.
On the website, yeah.
We really should. Thank you, Sam. Good idea.
Actually, on the
So,
website's a
email
great idea
link.
because it's dynamic, and as
Mhm.
things change, it can be easily updated.
It's a great idea.
Yeah.
But I think that information should be available.
That's great.
Good idea.
We'll all be getting more phone calls and emails.
Not all of us.
Yeah.
I will get less.
Just a quick caution though, if you guys are using email, remember it's not encrypted, you can't be using patient demographics, so.
Unless you get an email from St. Peter's, in which case it is.
You can't open it,
You
so.
can't
open it.
It doesn't-
It's
but
so well
that's the good
encrypted.
part about it, you can never, patient information is safe, you just can never open it. But yeah, just, probably a good idea, like, call me about so-and-so rather than putting
Yeah.
down the name and all that.
Anything else from the floor? Remember, October meetings, canceled. Motion to adjourn? Second? Discussion?
Let's have a discussion on that.
Thank you, everybody.
Who has the attendance sheet?